everybody. Paul Singh here from the Eye Centers of Racine and Kenosha out here in southeastern Wisconsin. Thank you so much for the opportunity to be part of the Interventional Mindset series. I'm going to talk to you about the Omni device, a device I've had the pleasure of working with now for the last couple of years. It's a device that viscodilates to actually open up the Schlemm's canal as well as the distal channels, at the same time give you the opportunity and option to perform a cutting procedure or an otomy as well. I'm going to go through some of the patient selection issues, as well as some of the intraoperative pearls, and some of the postoperative management to hopefully give you the best chance of being as successful as you can with the Omni device. Here are my disclosures. I do speak and consult for a lot of the companies in the MIGS space, but I do also consult and work with Sight Sciences, who also manufactures the Omni device. Now, I think we're just so lucky to have all these options at our disposal to help really tailor the treatment for the right patient, whether it's indications, whether it's anatomy, whether it's target pressures, or if it's just comfort level of the surgeon. And this was a picture I had a couple years ago. You can see the side passes there. But it was a nice day because I had all these different procedures in one day because each patient was different. And there's no perfect solution or perfect patient. And that's why I think we need all these options. And one of the issues that we face, I think, with preoperative assessment of our patients is we don't know where the resistance to outflow is, right? Is it the trabecular meshwork the issue, the Schlemm's canal, the distal channels? And we don't have a great diagnostic tool that tells us where is the resistance to outflow. This is why sometimes if we just bypass the TM alone, it'll work for a lot of patients, but in some patients it might, if the distal channels are the main source of resistance. So if you look at data and if you look at pictures like this, we do know that the Schlemm's canal is not equally open throughout. There are some areas of stenosis, and it's not perfectly circular, and the distribution of our collector channels are also not equidistant throughout the entire Schlemm's canal. And to this end, Haiyan Gong has shown us great work that shows us 50% of our patients who have primary open-angle glaucoma actually have complete herniations or actually blockage of the ostial opening into the collector channels. And here's a nice slide that really illustrates this from the same study. On the top, you see how they have a nice, beautiful Schlemm's canal, and you can see the opening into the ostia of the distal channels. On the bottom, you can see how the canal's collapsed and actually blocking the opening of the distal channels. So therefore, if you just put a stent through there, or let's say even do SLT preoperatively, you may not actually have the impact you want if the canal is collapsed or if the distal channels are completely blocked from the Schlemm's canal as well. And so to me, preoperatively, I'm trying to figure out where is the resistance to outflow. Did someone have a failed SLT? If they did, does that tell you potentially that maybe the resistance is not this trabecular meshwork as well? People who are on multiple medications, 3, 4, plus 5, let's say medications, regardless of how advanced the disease is. So in other words, you could have a mild disease patient, pre-parametric or early glaucoma damage on the field, but yet have high resistance severity, meaning you're on 3 or 4 meds, pressure 24. To me, the longer they're on medications, the more medication someone's on, my assumption is probably some resistance beyond the TM, maybe in the Schlemm's canal or the distal channels as well. And this helps me figure out, should I also viscodilate as well, or even possibly perform a cutting procedure depending on the patient and depending on the indication as well. Is it a cataract or no cataract? As I mentioned before, I think we're so lucky to have all these options. And I use all of them, actually. And I perform a lot of stenting, whether it's iStent or Hydrus, during cataract surgery. But there are patients where maybe those stents aren't enough. Maybe we have to hedge our bets to open up the Schlemm's canal and the distal channels and put our stents in. So I'm actually going to talk to you also about potentially combining viscodilation with the Omni device with these stents, iStent or Hydrus as well. And I'll show you some videos in a few minutes. But I think the Omni device, which is a device just as well as the iTrack catheter, allows us to open up the Schlemm's canal, viscodilate, break those herniations like I showed you before to kind of physically open up the Schlemm's canal. And then by pushing viscoelastic, flushing out the entire system, kind of like rotor-rootering the entire outflow system, and then we can maintain our patency with those stents if it's a cataract. If it's a standalone, consider doing a cutting procedure as well. I'm going to show you an algorithm that I use at the end of this video that kind of describes kind of how I pick which patients. All right, well, let's look at an actual Omni video. So here's a patient where I'm doing 360-degree viscodilation, 180-degree otomy. And the reason I chose this option and this combination was because the patient's pseudophakic, pressure's in the lower 20s on 4 classes of medication. My target pressure, moderate glaucoma, more middle teens or so, middle, even upper teens possibly. Patient was non-compliant with medications. So I told the patient, look, you might not be off of all medications. If I can get you off of 1 or 2, maybe 3 medications, just on a PGA, let's say, and the pressure down to the middle to upper teens, that's success, avoiding a trabeculectomy or a subcon surgery as well. And because because the patient had SLT in the past, which had some moderate response, I figured the resistance is beyond the TM in the Schlemm's and distal channel. So I wanted to viscodilate, but also I performed 180-degree otomy, not 360 otomy, because I really feel that there's a lot of patients who maybe 180-degree otomy is enough. How many collector channels do we have to access to get full response? We don't know. But also, if you limit the 180 degrees, you have less chance of intraoperative and post-op hyphema. And even post-operatively, you can go back and do SLT in the untreated or the uncut 180-degree angle as well. So that's why I chose 360 viscodilation, 100-degree otomy. So let's take a look. Here we are trying to find the best view possible, any MIGS procedure. I'm having the patient turn the eye a little bit more nasally. You see a nice, beautiful view of the TM, the sclerospur, the ciliary body band. Zoom in here as well. Trying to get that en face view. You want that TM to face towards you, almost perpendicular versus facing downward. Now, as I enter the eye with the Omni loader here in a second, I'm going to enter and really engage the TM, score it a little bit there, but engage at about a 45-degree angle towards the trabecular meshwork. The actual catheter comes out more towards you, more parallel, so you want to engage and aim towards the nasal angle. Advance the wheel till it stops, about 180 degrees. It'll advance and then retract it back as it releases about 5.5 microliters of viscoelastic. Now, you want to come out, or if you really feel comfortable, it's a pseudophakic patient, you have a nice deep eye here, you can turn it within the eye and then aim again, 45-degree angle towards the nasal angle, and go the other 180 degrees. Advance it until it stops, then retract it back, but don't come out. Once it's about to retract fully, then re-advance it. Go again until it stops, 180 degrees, then pull back towards the main wound to perform your cutting procedure or your otomy. And that's really it. You see a nice little white line there where I performed the otomy. And the other 180 degree, I did not treat with the otomy, just viscodilated. So again, we're flushing the entire system out as well as cutting about 180 degrees to help the maximum outflow. All right, here's another video showing you kind of the nuance of how to engage the nasal angle. Here I'm with my Omni loader, and I'm actually almost parallel to the TM. So as I advance my wheel to release the catheter, you see how it's kind of coming at me, more parallel, not engaging the TM very well. So I'm going to re-engage about a 30-degree angle, put a little bit of pressure there, and try to advance it again. But here I am still, it's kind of bouncing off, coming at more parallel. So I'm going to refocus, re-engage, put more pressure at the nasal angle, and about a 45-degree angle, now you see how I advance it, and the catheter now is turned dark, which means I'm in the Schlemm's canal. So I didn't score the TM here, I just kind of let the catheter do all the work. I'm going to re-advance it now until it's about 180 degrees, until it stops, and then retract it back as it releases viscoelastic. But I'm not going to come all the way out. This is 180-180, meaning 180-degree viscodilation, 180-degree otomy. So I'm just going to re-advance it without coming out, re-advance it till it stops, and now I'm going to perform my otomy. I'm going to zoom out, come back towards the wound itself, and I'm performing my 180-degree otomy. You may maybe perform 150 or 160 degrees right at the edge where the wound is. You may not have that last few degrees. You may not have a full cut there, but 150 to 160 degree otomy has been performed right there. As I remove the viscoelastic here and perform manual INA, you see a beautiful blanching. Look at that. I love this. This is an intraoperative verification that we've actually done something and improved outflow facility. And you can see those three arrows highlighting or delineating where we've improved outflow facility there. What's also important for any cutting procedures is hyphemas can happen. And so I like to overfill the eye, kind of hyperinflate it, and I don't decompress it right away. Overinflate it, wait about a minute or so or two, then slowly decompress, wait, slowly decompress, wait. That prevents hyphema intraoperatively and in the immediate post-op period as well. So I think giving it time to equilibrate is really important for these procedures. Okay, hopefully those videos helped you. I'm going to share with you a couple more videos. Just want to talk to you about this idea of combining different MIGS procedures or mechanisms of action. Now, Omni itself does combine mechanisms of action, viscodilation and cutting. You can't bill for both of those. Now they bundle them. But I think what has been a big benefit is, especially if you have a cataract, is combining stenting as well as viscodilation, which you can combine because the stent is a T code and the Omni or viscodilation is a level 1 code, canaloplasty. By combining those, though, from a mechanism of action, it makes sense. We're actually flushing the entire system out, right? The Schlemm's canal and distal channels, and you maintain the patency with your stenting. And if you have a cataract, you only have one opportunity to perform a stent. I don't want to lose that opportunity. At the same time, I want to hedge my bets to allow the entire system to be patent so the stents can work properly. I'm just going to show you a couple of videos here. One here is going to be the eye stent with the viscodilation, and one's a hydrus with viscodilation. All right, well, now here I am with my Omni loader. I'm not going to do any otomy. I'm just going to go ahead and perform 360-degree viscodilation to flush the system out and then place my eye stent. So I'm just going to go ahead, do my 180-degree viscodilation one direction, again, engaging about a 45-degree angle like we showed you earlier. Come back out, go back in, go ahead to 180 degrees the other side, advance the wheel, advance the catheter through the canal, make sure it's fully advanced, retract it back, and I'm releasing viscoelastic. So you see there, I'm just viscodilated, didn't perform any cutting procedure. Now I'm going to place my iStents. Now this is the iStent inject, not the W. So you got to be a little careful with all these first version iStent injects that you don't want to push too hard because you've stretched open the canal, so you have a potential to over inject or over implant these if you push too hard. So I'm just gently pushing, barely any dimpling there, and advancing those stents into the Schlemm's canal. Beautiful position there. You see a small white area where I perform my viscodilation, small otomy just nasally there. But the beautiful thing about this is I've flushed the entire system out, and you can see here now this beautiful blanching as I'm doing automated INA. See the nice fluid wave there as I press the pedal. And just I love this. This is my favorite part of any of these MIGS procedures, showing us this increased outflow facility with this procedure. And I think with viscodilation and the iStents, the chance of hyphema is definitely a little bit less than the cutting procedure, and you've also maintained patency with those stents and flush the system out, slowly decompressing the eye. Well, here's a patient I'm doing actually viscodilation with the Omni device and hydrus. Patient has a cataract, and during the COVID time period, this was actually early on, where patient was actually pressures in their 30s on multiple medications. Although it was more mild to moderate glaucoma, I was really concerned, and I wanted to get the patient the best chance of being off of medications if possible. And so I'm performing my 360-degree viscodilation with the Omni device here as well. And again, I think you see a beautiful angle TM facing actually that en-face view. You can get some heme reflux here you see during the procedure as well, but I think once you're engaged in the Schlemm's canal, you don't have to do much more movement, just leave that loader there. And I'm performing my 180-degree otomy, so 360 viscodilation, 180 otomy. Now through that uncut TM, I'm going to place my hydrus to maintain the patency of that 180-degree viscodilated area. So I'm just going to go ahead and advance this hydrus here, and it fits in beautifully, just smooth like butter. I love it. And you can see here, as I remove viscoelastic, the hydrus is in beautiful position here. So I viscodilated, 180-degree otomy, and I have a stent sitting there to help me maintain patency and then scaffold in that Schlemm's canal as well. So this is an example of really combining multiple mechanisms. This patient is doing really well. Pressure's 14, believe it or not, off of medications from 30 plus on 4 meds. Now, it's not always going to happen that way, but I think that's where the big benefit comes in, is that pressure's still going to be in the middle teens. It's a conventional outflow facility procedure. But I think that you have the ability now to reduce the drop burden. And we found in our studies, you do cataract surgery with a stent versus with the viscodilation. The viscodilation really does help improve the chances of patients being off of medications. And here you go, I'm just removing viscoelastic here, and you can see just, again, with that arrow, just a nice fluid wave here where we perform my otomy there. Just a beautiful, nice blanching again. So I think combining these procedures might be a benefit for certain patients who actually need the full outflow facility enhancement, so to speak. All right, everybody, we're almost done. Hopefully those videos helped you. Let's leave it with a couple more slides here and just more discussion on really my algorithm. How do I decide viscodilation with otomy, 360 otomy, 180 otomy, and how do I know? And really for me, the bottom line is the more advanced, the more number of medications, the more I'll perform an otomy, the more mild they are, if they're phakic and no lens, or rather a cataract yet, I'll perform more viscodilation, limit the otomy unless I have to as well. So here's a slide. I'm not going to go through every single detail of the slide. Just conceptually, this is kind of how I think. It's not 100% a guarantee of how I would perform all these procedures and make decisions, but it does show you if they have a cataract, they're more mild, I'll perform more just viscodilation or do the stent alone and no viscodilation. If they're more moderate glaucoma or more number of medications, I'll viscodilate and possibly do an otomy with the stent. If they're pseudophakic, or let's say phakic and have no cataract yet, I'll just perform viscodilation alone. Very rarely will I do an otomy if they're phakic, unless they're more moderate or severe disease on multiple medications. If they're pseudophakic and mild, I'll do viscodilation, 360 and 180 degree otomy. If they're pseudophakic and more severe, I'll do 360 viscodilation and otomy as well. Again, these are not steadfast rules by any means, but they're just kind of idea of how I think. And lastly, how do you manage post-op? I feel like we get confused a lot of times with hyphema and inflammation. A lot of times if you see hyphema, don't bump up the steroids naturally. Hyphema is red blood cells versus inflammatory cells. So I'll keep the steroids the same. Usually I'll use loteprednol of various forms, and then I'll let the blood reabsorb. And I think it's important to tell the patient ahead of time, you're making a connection into the bloodstream, into the venous system, and therefore there's a chance that blood vessels or blood refluxes back in because you have lower pressure in the eye, so blood is not a bad thing. It'll go away over time, and I think patients are pretty good with that. I do try to take them off their glaucoma drops if they're more mild to moderate and see what happens. I do follow them 1 day, 1 week, 1 month. If they're more advanced, I'll keep them on the aqueous suppressant, stop the PGA, and then treat them, of course, as needed as well. But again, I think the post-op management is pretty straightforward. Sometimes you can get a pressure spike post-operatively, especially when we think there might be retained viscoelastic. Even a week later, you can get a kind of a pressure spike. I think sometimes Diamox or even pilocarpine has been shown to help a great deal, as well as if you see a little bit of a delayed hyphema or a reflux of blood, let's say a week or two later, sometimes pilocarpine can help that in those patients. Again, I know it's a lot of information, a long video, but please feel free to email me anytime. My email address is ipsing@amazingeye.com. I wanted to thank the organizers of Interventional Mindset for allowing me to babble for this video, but hopefully we'll keep in touch and do more videos in the future. Thanks a lot.